Hello, my name's Selena Roberts and I'm an occupational therapist at the Royal Hallamshire Hospital in Sheffield. I currently work in specialised medicine and surgical oncology. I'm completing a master's module in contemporary issues in occupational therapy. And for my inquiry question, I'm looking at cancer-related fatigue. So why should we invest in it? What is known about it and what can be done about it? Occupation and occupational performance are central to the philosophy of occupational therapy. Occupational performance components in the context of OT can be grouped into sensory motor, cognitive and psychological, all of which are often related to cancer-related fatigue. It is the engagement in purposeful behaviours that has an organising and integrating effect on psychological and social functioning. Occupation is described as the ability to perform those occupational tasks that make it possible to carry out occupational roles in a satisfying manner that is appropriate to the individual's development stage, culture and environment. Engagement in occupations is the ultimate goal of therapy. OT use occupations therapeutically to support participation, performance and functional roles that are variable in nature, social, cultural and spiritual, and to promote habituation, rehabilitation, health and well-being, and support the management in life choice occupations that have purpose and meaning that affect physical and mental health, well-being and quality of life. Participation in meaningful occupation is a determinant of health. With reforms and changes in the NHS, demand and pressures on occupational services have meant that models have focused on compensatory and discharge assessments, thereby ignoring occupations undertaken to contribute to the well-being of others, occupations that foster connections to nature and ancestors, collaborative occupations, and those valued for their social context and potential to strengthen social roles. Habits can improve occupational performance by enabling them to become proficient. Conversely, aspects in a specific context of ineffective role performance may hinder a person's occupational performance. Evidence states that there are a number of resulting impairments with cancer-related fatigue. For example, physical, emotional, mental, social, psychological, cognitive and behavioural, much like the components allied to OT. It impacts on physical activities, activities of daily living, sleep quality, nausea, work, leisure and social activities, self-esteem and an inability to engage in activities that they therefore enjoy and quality of life is adversely affected. There is also a high probability that cancer-related fatigue will negatively affect the patient's participation in healthy behaviours. Over the past 100 years, lifestyles and occupations have changed dramatically, and OT has survived and continued to thrive and flourish because we have always adapted our practice to meet the needs of the people we serve. There are more than 30,000 OTs working in the UK, about 60% of them in the health service. OTs have historically been driven by the theories and models, yet new theories began to emerge to explain and direct interventions. By the second half of the 20th century, OT had expanded into many new areas and developed a greater understanding of the physical, social and environment of their patients and how they impact on health. We have re-emerged with the profession's core philosophy, occupation, and an emerging paradigm and a shift away from the mechanistic approach. Advances in surgical interventions and treatments have resulted in cancer survival rates increasing to up to 6 times longer than 15 years ago. However, certain cancer treatments increase the risk of longer-term conditions and can add to the other acute and chronic conditions common in older age and have devastating side effects, all of which can contribute to serious health and social care problems. There are currently over 2 million people living with and beyond a cancer diagnosis in the UK, and this will increase to 4 million by 2030. Patient Experience of Care Survey 2014 identified that 1 in 3 cancer survivors have unmet needs. Cancer-related fatigue is complex and multidimensional in nature, remains under-recognised and often undertreated. It is often overlooked as a potentially treatable condition. Cancer patients are hardly ever systematically asked about the symptoms and signs of their fatigue, and this complaint is seldom dealt with to the satisfaction of the patient. The annual cost of cancer care to health services in the UK is estimated to be between 5.5 and 5.8 million. Failing to address unmet needs will have further cost implications for the NHS and the wider economy, and increase pressures on health and social care resources. Fatigue is to be believed the most common and one of the most devastating symptoms in patients with cancer, and their most severe symptom. It is reported to be different to fatigue experienced by healthy individuals, as it cannot be relieved by sleep or rest. It can last for months, even years after treatment has ended. Prevalence in the United Kingdom suggests it prevents 91% of patients from living a full and active life. In terms of prevalence worldwide, European studies suggest that it affects between 17 and 90% of cancer patients overall. In the Middle East, it reports between 18 and 90%. And in the United States, surveys conducted by the Fatigue Coalition suggest a prevalence of 76 to 78. And approximately 30% of patients will endure persistent fatigue for a number of years after treatment is finished. Therefore, there is an urgent need to improve survivorship knowledge, particularly in developing a better understanding of the population who have unmet needs and how they can be met in a cost-effective way. One such area is the development of specialist rehab services, which include services for the management of cancer-related fatigue. The National Comprehensive Cancer Network can describe cancer-related fatigue as a persistent, subjective sense of physical, emotional and/or cognitive tiredness or exhaustion related to cancer or cancer treatment that is not proportional to recent activity and interferes with normal functioning. Over the past 60 years, Macmillan has had a huge impact on the development and improvement of cancer care services. It remains very influential in the development of improved cancer care and cancer survival, and is involved in many partnerships such as the National Health Service Improvement 2012 and National Cancer Survivorship Initiative. One such example is the Recovery Package. It has been developed, and its purpose is to assist people living with a diagnosis of cancer to prepare them for the future, identify their individual needs and support rehabilitation to enable people to return to work or a near-normal lifestyle. It aims to reduce psychosocial consequences, provide patients with strategies of how to proactively manage their physical, psychosocial and social recovery. Patients should be in a position to be helped to more effective self-management, to minimise the risk of long-term health problems and to make healthy lifestyle choices and increase their quality of life. Health and Social Care Act 2012 was designed to meet the challenges faced by National Health Service. It's the biggest reform and extensive reorganisation in the service since the NHS began in 1948. Increased demands on hospital pressures and financial constraints means joint partnership and integrated care from the NHS and social care services and the independent sector. Healthcare reforms have impacted on OTs throughout the world, and they too have made opportunities to promote the profession. In the United States, reforms have seen improvements in habilitation and rehabilitation, creating opportunities to ensure OTs are continually valued and protected in the future. Denmark sees the development of everyday rehabilitation, a community-based service that involves occupational therapy. Throughout the UK, there are many innovative services being created to improve quality, cost effectiveness and efficiency, in order for us to deliver more coordinated health and social care service. Shifts from acute inpatient assessments to community services offers the opportunity to work together more collaborative and put patients' needs first, increase their independence and deliver collaborative community-based services that meet the needs of the ageing population. With the ever-increasing, changing and challenging pressures on an OT service, it is paramount that we continually take and make opportunities to further enhance our professional development. With the plethora of survivorship evidence and evidence to support the role of OT in education in supporting the management of cancer-related fatigue, this is an opportunity where occupational therapy can utilise their skills. OT's distinct knowledge of the significant impact that habits and routines have on individuals' health and wellness will make their contribution to cancer-related fatigue distinct, and we need to explore the understanding and knowledge of cancer-related fatigue. Fokins 2004 recognised rehabilitation services should consist of multidisciplinary care, to which OTs play a vital role in equipping patients to achieve their goals and improve their quality of life. According to Dykes, 1980, who was an early founder of Cancer Rehab, and the National Coalition Action Team of 2008, suggested that there are 4 stages of cancer rehabilitation: preventative, restorative, supportive and palliative. Cancer rehab involves maximising a patient's functional independence with physical, psychological and vocational functioning, ensuring that they are able to live a full and active quality of life, health and well-being during periods of change, by enabling patients to make the most of their lives and help to minimise side effects and symptoms such as fatigue. With the increasing focus on meeting the needs of people living with and beyond cancer, the Department of Health has identified a need for a more coordinated and effective service, yet there appears to be a lack of services to meet the needs of cancer patients and survivors who suffer with these symptoms. Specialist care would enable patients to have chemotherapy and follow-up services in the primary care. There is also much evidence to support occupational therapy in the role of managing cancer-related fatigue in education programs, interventions such as teaching relaxation, energy conservation, and strategies to manage symptoms of breathlessness and fatigue, and they all have positive effects on patients. Lifestyle management programs are also of benefit. Fokins 2004 suggests that fatigue management fits easily into the toolbox of OT by devising strategies to cope with fatigue and look at lifestyle management and energy conservation techniques. Evidence demonstrates the efficacy of many OT interventions, so why should this analogy be limited to Macmillan OTs, who appear to have significant financial support in developing cancer services? Wherever OTs work in whatever speciality, we should all have a voice. OT has a significant opportunity to offer assistance in the engagement in meaningful occupations. OTs are able to understand the effect of occupational dysfunction and deprivation on individuals, and recognise the importance of restoring and facilitating opportunities with the aim of achieving occupational wellness. Since the beginning of occupational therapy profession, engagement in occupation has been valued as the primary therapeutic agent, as well as the goal of intervention. While there are few today who would not support this, occupational therapists continue to struggle with implementing their beliefs through what we do and how we do it. We need to ensure that we continually promote our beliefs and purpose to ensure we justify our profession, maximising the power of occupation in practice. So I've tried to look at how I might develop a cancer-related fatigue management programme using the evidence to support this.